Welcome to yet another virtual lecture, which is going to focus on topographic anatomy of the thigh. Just to bring you to perspective, we are doing a series of topographic anatomy of the lower limb. And so this particular lecture we're having is the second lecture in this particular series. The first one that we dealt with was topographic anatomy of the gluteal region. From the list that I am projecting, you can see that we still have some other lectures that we are going to look at as we talk about topographic anatomy of the lower limb. Just to remind you about the key segments of the lower limb, that we have the gluteal region, which we call the buttocks, and that one we've already covered. We have the thigh, which is this segment. And as the segment we are going to learn in this particular lecture, we have the leg, which is this one, and we have the foot, which is the one down. Of course, there are also various joints, as you've seen in the previous slide, that we'll also be learning. So in this particular session, where we are looking at the topographic anatomy of the thigh, what exactly are we going to learn? First and foremost, it will be important that we familiarize with the topographic anatomy of the bones which are around this region. The principal bone in the thigh is femur, and so we look at topographic anatomy of the femur. But there are some parts of the pelvic bone that are also relevant in the understanding of the topographic anatomy of the thigh. So we'll also look at that relevant topographic anatomy of the pelvic bone, even as we study osteology of the thigh. And then there'll be some important landmarks that we'll also be highlighting as we do that. After we looked at osteology, we'll try to look at the things which are subcutaneous. So in this particular region, we'll focus on the subcutaneous nerves, those nerves that supply the skin of the thigh. As we do that, we'll also highlight on the concept of dermatomes. Other than the cutaneous nerves, we'll also focus on the superficial veins, which are in the thigh. And then we'll talk about the superficial lymph nodes. And for the lymph nodes, we want to know the territory that they drain. After the subcutaneous structures, we'll go slightly deeper and we look at the deep fascia of the thigh, which we call the fascia lata. On this one, we look at the attachments as well as the modifications of the fascia lata. Beyond the deep fascia of the thigh, we go deeper and we find the muscles. The muscles of the thigh are organized in compartments. These compartments are made by fascia and bone, and some call them osteofascial compartments. They are the ones that carry the muscles of the thigh. So we look at these compartments, there are three. We look at how they come about. We look at the contents of each compartment, principally focusing on the muscles and perhaps their nerve supply. After that, we look at various anatomical spaces in the thigh. So we have quite a number of anatomical spaces in the thigh. We have what you call the popliteal fossa around the thigh. Well, it's way not exactly in the thigh, but behind the knee. But with this, the best time to talk about it. We'll look at the femoral triangle. Within the femoral triangle, there's something called the femoral sheath. And somewhere mid-thigh, we have what you call the adductor canal. So we look at those anatomical spaces. For each space, it will be important that we familiarize with where it's found, the boundaries or the borders, the contents, which means the structures found within it, and how this space is clinically important. So that is what we'll focus on concerning the anatomical space. That will take us quite a while though. After that, we'll just give a descriptive anatomy of the key neurovascular structures in the thigh. The key neurovascular structures here, we are referring to the key blood vessels, the key nerves. So we'll look at those ones. Great. So having said so, let's address the first agenda, which is the relevance osteology. I'll start with that one of the pelvic bone. In the previous session, we looked at the relevant anatomy of the pelvic bone, and we largely focus on this gluteal surface of the pelvic bone. I don't want us to repeat that, but just to build on that. At this particular time, emphasizing on the parts of this bone that are relevant for our understanding of the anatomy of the thigh. We are aware that this bone has three bones which are fused at this point, which we call the acetabulum. The bone above there is called the ilium. So the parts of the ilium that are important in our understanding for this session will be the iliac crest, which you remember even from the previous session. That's the iliac crest. And along the iliac crest is this region here, which we call the iliac tubercle. Also important to understand for this session is the fact that the ilium has some spines, both anterior spines as well as the posterior spines. The posterior spines are largely for the understanding of the gluteal region, but the anterior spines are vital in this particular session. We're going to understand the anatomy of the thigh. So we have the anterior superior iliac spine and the anterior inferior iliac spine. Regarding the ischium, which is this one, also there's some things you need to know about the ischium. One of them is this one, the ischial tuberosity. We talked about in the gluteal region. It's also going to come up in this particular session. Apart from the ischial tuberosity, we also have this part here, which we call the ischiopubic ramus. The ischiopubic ramus is formed by two rami. Ramus means branch. Rama is the plural of ramus. This one here from the ischium going that way is the ischial ramus. And this one is the inferior pubic ramus. From this pubic bone, so this is the inferior pubic ramus. So the inferior pubic ramus and the ischial ramus are fused to form what we call the ischiopubic ramus, a union of the ischial ramus, the ramus of ischium, and the inferior pubic ramus constitute the ischiopubic ramus. So that's the ischiopubic ramus. Things about the ischial spine we talked about in the previous session, not so quite going to be relevant in the anatomy of the thigh, but at least to remember it from the gluteal region. For the pubic bone, we've already mentioned, so perhaps the body of the pubis is somewhere here, with that projection being the pubic tubercle. So this is the superior pubic ramus, the one that goes towards the acetabulum. And this is the inferior pubic ramus, the one that join with the ischium to form the ischiopubic ramus. The pubic crest is that region, and that's the pubic tubercle. Of course, we remember the socket of the hip joint, which we call the acetabulum. We'll talk more about the anatomy of the acetabulum in the next session when you look at the anatomy of the hip joint. And this is the obturator foramen. Remember that the obturator foramen is usually covered by a membrane, the obturator membrane. So this image shows us the obturator foramen, which is covered by a membrane, the obturator membrane. And that even though we have the obturator membrane, there's a gap on the upper part of it, which is not covered by that membrane. And that gap is called the obturator canal. It's going to be vital in this particular session. There's a ligament that connects the anterior superior iliac spine to the pubic tubercle. That ligament is called the inguinal ligament. It's going to be important in this particular session. There's some reflections from the inguinal ligament on the middle aspect, which we call the lacunar ligament. It's also going to be important in this session. That's the lacunar ligament. And there's further extension of that going backwards, which we call the ligament of Cooper, the pectineal ligament of Cooper. Again, that's going to be important in this particular session. So take note of the ligament of Cooper, the lacunar ligament, and the inguinal ligament. So that is with regard to the pelvic bone. Now we can look at the femur itself. So the femur has a number of parts. On the first image there, we're looking at femur anteriorly, and this one is the posterior aspect of femur. We had already mentioned about the head, neck of femur, the greater trochanter, and the lesser trochanter of femur. This is the femoral shaft, and these rounded structures down here are what we call the femoral condyles. So we have the medial femoral condyle. You know it's medial based on the direction that the head and the neck of femur is facing. So this is a medial femoral condyle, and that becomes a lateral femoral condyle. The condyle anatomy may be a bit complex. I'll prefer talking more about it when you look at the anatomy of the knee joint complex. But all in all, the posterior aspect of the femoral shaft has this ridge here, which we call the linea aspera. Usually it has two lips, the medial lip and the lateral lip of the linea aspera. When you follow these lips of the linea aspera proximally, they'll take you to some lines. The lateral lip takes you to the gluteal tuberosity that we had already mentioned in the previous session. And the medial one also takes you to what we call the pectineal line, which you can see there. So this is the pectineal line there. And there's this other one here, which we call the spiral line. The spiral line may extend proximally and appear to be continuous with the intertrochanteric line. The pectineal line, on the other hand, extends slightly inferior to the lesser trochanter there. Down here, the two lips of the linea aspera project towards the condyles as the supracondylar lines. So we have the medial and the lateral supracondylar lines as well. The space between the two, this region here is a smooth surface we call the popliteal surface of the femur. So this is the popliteal surface of femur. It's going to be important in this particular session. So that is what I wanted to mention about femur. Radiologically, this is how femur looks like. So we see the head of femur there, the neck of femur, greater trochanter, lesser trochanter. We can see that femur has a medullary cavity there. So this is the cortex of bone. This is the medullary cavity. So this is the proximal femur and this is the distal femur towards the knee joints. Having looked at the osteology, we can now talk about the structures which are in the subcutaneous regions of the thigh. We'll focus on subcutaneous nerves, superficial veins, and superficial lymph nodes. We start with the superficial nerves, the cutaneous nerves. So there are a number of nerves that supply the thigh, indeed very many, but we can make it simple. The posterior thigh is supplied, the skin of the posterior thigh is supplied largely by the posterior cutaneous nerve of the thigh, which is usually an S123. And so the dermatome of the skin of the posterior thigh will be S123, and usually S1 will be slightly on the upper part, then 2, then 3 as you go down. That's posterior thigh. The skin of the anterior thigh, on the other hand, are supplied by the cutaneous branches of the femoral nerve. So we have the intermediate cutaneous nerve of the thigh, which is a branch of the femoral nerve. We have the medial cutaneous nerve of the thigh, also a branch of the femoral nerve. So these ones come from the femoral nerve and they supply the skin of the anterior thigh. And so that region there will be contributing to L2, L3 dermatome, with L2 being on the upper part and L3 being on the lower part around the knee joint, that is L3. How about skin of the lateral thigh. The skin of the lateral thigh is largely by this independent nerve, the lateral cutaneous nerve of the thigh. The lateral cutaneous nerve of the thigh is an L2, L3 nerve, and so it is to apply the skin of the lateral thigh, with L2 being slightly on the upper part and L3 on the lower part. Then skin of the medial thigh is contributed by various nerves. On the upper part, we have the femoral branch of the genitofemoral nerve contributing. We also have the ilioinguinal nerve contributing on the skin on the upper part. We also have the abductor nerve contributing somewhere still on the medial thigh. So femoral branch of the genitofemoral nerve, ilioinguinal nerve, the obturator nerve, and finally the medial cutaneous nerve of the thigh are all the nerves that supply the skin of the middle aspect of the thigh. They contribute to various dermatomes on the upper part, could be mostly L1. As you go down, we go to L2 and then L3 down. So basically that summarizes the cutaneous innervation of the skin of the thigh. I will not focus on the leg for now in this particular session, but we can talk about that in the relevant session. What is important for you to note about the skin of the thigh is various dermatomes. So I'll encourage you to pick another atlas that specify the dermatomes. Maybe we define what a dermatome. A dermatome refers to a skin segment supplied by a single segment of the spinal cord. Understand that the spinal cord has various segments, and these various segments of the spinal cord give rise to nerves, which we call spinal nerves. So the segment of the skin that is supplied by a single segment of the spinal cord is what we are calling a dermatome. So when you say the skin of the anterior knee is dermatome L3, it means that the spinal nerve L3, the spinal cord segment L3, is the one that contributes to the cutaneous innervation of the skin of the anterior thigh and the anterior knee. So we expect you to be knowing dermatomes of various regions. You cannot know that in one sitting. You'll have to be interacting with your atlas more often than not for you to grasp that particular concept of dermatomes of various regions, not just the thigh only. Apart from talking about this cutaneous nerves, the other thing which is also subcutaneous are the superficial veins of the thigh. So let me put it this way. There are two major superficial venous systems in the lower limb in general. There are many veins, but the systems, there are mainly two major superficial venous systems. There's what we call the small saphenous venous system. This one will not be so much in the thigh, but it will be more in the foot and leg, because it terminates somewhere behind the knee in a vein we call the popliteal vein. So that one will not major much in this particular session. But the other one is what we call the great saphenous vein. I'll want to talk about great saphenous vein in great detail when we look at the anatomy of the leg. But in a nutshell, the great saphenous vein is a large vein that begins from the foot and runs on the middle aspect of the lower limb. So it will run on the middle aspect of the foot, leg, knee, and the thigh as well. And then it terminates somewhere up in a vein we call the femoral vein. The femoral vein is a deep vein. Deep veins run with arteries, but superficial veins do not run with arteries. So the superficial veins are subcutaneous, they don't run with arteries. So this great saphenous vein is the main vein, superficial vein in the thigh. And so all the other superficial veins appear to drain towards it, as we can see in this particular image here. The great saphenous vein is there. draining all the way to the femoral vein, but we can see various veins joining it. So in summary, the great saphenous vein begins in the foot, runs in the middle aspect of the foot, as well as leg, knee, and the thigh, and then it terminates in what we call the femoral vein, quite up there. This great saphenous vein is joined by various veins. Some of them are named, some of them are not named, but it's important to know that majority of the superficial veins of the thigh drain to the great saphenous vein. Towards its termination into the femoral vein, the great saphenous vein enters a particular opening, which we're going to talk about later shortly. We call it the saphenous opening, to enter into the great saphenous. And before it terminates there, it is joined by some 3 superficial veins, which are worth mentioning at this point. We have what we call the superficial epigastric vein that joins it. This is a vein that drains the subcutaneous region of the anterior abdominal wall, the lower part of the anterior abdominal wall. So you realize that the superficial veins of the anterior abdominal wall also drain into the great saphenous vein. The other vein is what we call the superficial circumflex iliac vein, which is this one. Again, it rotates, it runs around the ilium and partly draining even some parts of the gluteal region. It drains also into the great saphenous vein. The last one is a superficial external pudendal vein, which drains the region around the genitalia. Superficial veins from the genitalia drain into the great saphenous vein. So those 3 superficial veins join the great saphenous vein just before the great saphenous vein enters into the femoral vein. Those veins join it at around what I've called the saphenous opening. Important to note that the superficial veins usually run with superficial lymphatics as well. And so you'll be having some lymph nodes that are related to the great saphenous vein. We call them superficial inguinal lymph nodes. We'll talk about them in the next slide. Similarly, because we have small saphenous vein also being subcutaneous, there's some lymph nodes that are around its termination. We call those ones popliteal lymph nodes. Again, we'll talk about it at the right time. The last image here captures for us the great saphenous vein, its territory, as well as the various cutaneous nerves of the thigh, well, the whole of the lower limb, but we are emphasizing the thigh at this particular point in time. I've already talked about those superficial structures. Now let's talk about the superficial inguinal lymph nodes. Superficial inguinal lymph nodes are the lymph nodes which are around the termination of the great saphenous vein. When you say they're superficial, it means they're above the deep fascia of the thigh. They're not deep to the deep fascia of the thigh. So they are superficial to the deep fascia of the thigh. That's what makes them superficial. Superficial lymph nodes usually accompany veins, and deep lymph nodes usually accompany arteries. That's the general organization of how lymph nodes are. So superficial inguinal lymph nodes are in 2 categories. There's a group that are actually along the termination of the great saphenous vein. We call that group the vertical group, or the perpendicular group of lymph nodes. So those ones are along the termination of the great saphenous vein. The ones which are along the termination of the great saphenous vein are the ones which drain the lymph that were accompanying the great saphenous vein. Having looked at the territory of the great saphenous vein as being the middle aspect of the foot, middle aspect of the knee, middle aspect of the leg, middle aspect of the thigh, the lymph nodes which are in this particular vertical group also drain all that territory. And indeed, we can make this strong statement that this vertical group drain the superficial lymph that come from the foot, the leg, and the thigh. The whole of it, except the ones which go to the popliteal lymph nodes, the ones which accompany the small saphenous vein. And so maybe at this point in time, then it's important also to highlight then that territory for the small saphenous vein. The small saphenous vein is on the lateral aspect of the foot, the posterior lateral aspect of the ankle, and then the posterolateral calf. Then it terminates into the back of the knee, what we call the popliteal fossa. So only that territory of the small saphenous vein will the lymphatics also not drain to the perpendicular group of superficial inguinal lymph nodes. The regions of the lower limb not drained. The regions of the foot, leg, and the thigh, which are not drained by the vertical group of superficial lymph nodes, are the regions which drain into the popliteal lymph nodes. And they drain to the popliteal lymph nodes because they accompany the small saphenous vein. So if you understand the territory of the small saphenous vein, then you'll understand that exception. Lateral foot, lateral ankle, posterolateral calf. Keep it to that simple. So that's the vertical group. Then you have the horizontal group or the transverse group of the superficial inguinal lymph nodes. The transverse group or the horizontal group appear to be just below the inguinal ligament. So we can say they are arranged along the inguinal ligament or just below the inguinal ligament. This vertical group is divided into two. There's the lateral portion of the horizontal group, and then there is a medial portion of the horizontal group. The lateral portion of the horizontal group of lymph nodes are the ones which accompany the superficial circumflex iliac. They also accompany the superficial epigastrium. And so they'll be draining superficial lymph from the gluteal region and also from the anterior abdominal wall. That's their territory. Then the medial group of horizontal nodes will be the ones that accompany the superficial external pudendal. So this one will be draining the external genitalia, but they also drain some part of the anterior abdominal wall. So that the territory of the superficial inguinal lymph nodes, vertical and horizontal group. Vertical group along the great saphenous vein termination, draining leg, foot, thigh, with some exceptions which go to the popliteal nodes. The horizontal group divided into medial and lateral portion, the medial group draining the external genitalia and some parts of the anterior abdominal wall, the lateral group draining the gluteal region and again some parts of the anterior abdominal wall. Now, it is important for you to understand the territory of the superficial inguinal lymph nodes because occasionally these lymph nodes may be swollen because of some infection coming from some parts of the lower limb. So understand that if there is an infection perhaps in the big toe, then you'll expect the superficial inguinal lymph nodes to be the ones being affected, hence they swell. But if there's an infection on the small toe, we will not expect this superficial inguinal lymph nodes to be swollen, but perhaps we'll expect the popliteal lymph nodes to be the one which are being involved. Now we can go to the third agenda, which is talking about the fascia lata, focusing on its attachments and modification. The fascia lata is the deep fascia of the thigh. It's a bit tight, and so it also encloses the musculature of the thigh. So it has multiple attachments, and it continues the gluteal fascia, as we mentioned in the previous section. It will attach proximally to a number of things. It will attach to the iliac crest. It will attach to the anterior spherical spine. It attaches to the inguinal ligament. It attaches to the pubic tubercle, as well as around the pubic symphysis, and then going round to attach to the sacrotuberous ligament and attach also to the sacrum. So it's an extensive proximal attachment. The distal attachment is largely to the bones of the foot, bones of the legs. So it will attach to the tibia, it will attach to the patella, it will attach to the fibula, and it will also blend with the fascia of the leg. The fascia of the leg is called fascia cruris. The deep fascia of the thigh has some modifications that I want to highlight on. One of them is what we call the iliotibial band or the iliotibial tract. The iliotibial band is a lateral thickening of the fascia lata. So the fascia lata is significantly thickened on the lateral aspect of the thigh to form what we call the iliotibial band. This iliotibial band attaches distally to the tibia. But proximally, the band receives two muscles. It receives the muscle which we call tensor fascia lata from the anterior aspect. And that is why that muscle is called the tensor fascia lata, because it makes the fascia lata be tense. In fact, it makes the iliotibial band to be tense. Posteriorly, it receives most of the fibers of the gluteus maximus muscle. If you remember from the previous session, gluteus maximus has two major insertions: the iliotibial band, capturing the proximal 3/4 of the fibers of the gluteus maximus, and gluteal tuberosity, capturing the distal 1/4 of the fibers of gluteus maximus. So two muscles insert into the iliotibial band: gluteus maximus posteriorly and tensor fascia lata anteriorly. We'll expect tensor fascia lata to be somewhere here and gluteus maximus to be somewhere here. They both insert into the iliotibial band, which is the thickening of the fascia lata. The second modification I want us to talk about is what we call the saphenous opening. So this is an opening in the proximal anteromedial thigh for the passage of the great saphenous vein. We've mentioned that the great saphenous vein is a subcutaneous vein. It's a superficial vein. So it is external to the fascia lata. But the femoral vein is a deep vein. So it is enclosed by the fascia lata. The two need to communicate. The great saphenous vein must go through the fascia lata, therefore, to enter the femoral vein. How does it do that? By going through the saphenous opening. So it's a gap left for the passage of the great saphenous vein. However, the great saphenous vein is not the only thing that goes through the saphenous opening. Apart from the great saphenous vein, we also have some superficial neurovascular structures which traverse the saphenous opening. We've mentioned about those veins that were terminating at the great saphenous vein. They do that actually around this point. So the superficial external pudendal, superficial circumflex iliac, and superficial epigastric can be viewed to be also going through the saphenous opening because they actually enter the great saphenous vein at this particular point. Apart from that, we also have lymphatic vessels. We mentioned about superficial inguinal lymph nodes being external to the deep fascia. But we also have deep inguinal lymph nodes, which are now deep to the deep fascia. The superficial inguinal lymph nodes drain to the deep inguinal lymph nodes. So the lymphatic vessels which connect the superficial inguinal lymph nodes to the deep inguinal lymph nodes pass through the saphenous opening as well. Apart from that, we have what we call the cribriform fascia. Now, in principle, the cribriform fascia may not exactly be a modification of the fascia lata per se because of this. Cribriform fascia is the superficial fascia that cover over the saphenous opening. And so over the saphenous opening, this fascia, which is part of the superficial fascia of the thigh. But now, because over the saphenous opening, the deep fascia is lacking, it is only the superficial fascia that is there. And this superficial fascia is perforated by those many structures we just mentioned that go through the saphenous opening. Because of that perforation, this cribriform fascia is sieve-like, and that's why it's called cribriform, sieve-like. So in principle, to just be the superficial extension of superficial fascia over the saphenous opening. But yes, some people consider it a modification of the fascia lata. Last but not least, we have what we call intermuscular septae. So these are extensions that arise from the fascia lata to go all the way to the femur and especially around the linea aspera, helping to divide the thigh into compartments. So there are septae which enter from the deep fascia to the bone, hence dividing the thigh into compartments. And because these septa pass between muscles, we call it intermuscular septae. Having said so, we can now talk about the compartments of the thigh, because it is this septa that help us to divide the thigh into the compartments. So these are cross-section of the thigh, that is skin. And so this is subcutaneous tissue, largely containing fat. But within that fat, we've mentioned a number of things. We have cutaneous nerves. We have superficial veins like this one, perhaps that's the great saphenous vein. And we also have lymphatic vessels, which terminate into superficial inguinal lymph nodes. Beyond the superficial tissue, subcutaneous tissue, we have the deep fascia of the thigh, which is this one, which we call the fascia lata. So this is the fascia lata. Fascia lata sends in septae, like this one, written the lateral intermuscular septum, that one. We can also see this one going in all the way to the femur, and especially near the linea aspera there. So these septae, as we can see, tend to divide the thigh into compartments. And so we have compartments. We have the anterior compartment. So this is the group of muscles which are in front of the thigh. The anterior compartment is also called the extensor compartment. We have the posterior compartment in blue. So this is the compartment of muscles behind the thigh, also called the flexor compartment, and we'll see why. And then you have this medial compartment, the middle aspect of the thigh, which is also called the adductor compartment, and we'll see why. So these are the three muscular compartments of the thigh. I want us to look at each compartment one by one and seeing the kind of muscles which are located in that region and what these muscles do and their innervation. But remember, in the previous session, I told you how to describe the topographic anatomy of a muscle. There's a particular template that I gave in the previous session. We are not going to go into that in this particular session, but I'll just give a summary. But we agreed that for you to fully understand topographic anatomy of muscles, then you need to pinpoint each of those things, which you can check and also read now from a textbook. Now, we'll start with this one in blue, the posterior muscular compartment of the thigh. The posterior muscular compartment of the thigh refer to the muscles which are behind in the thigh. These muscles which are behind the thigh, if they contract, think about what they'll do at the knee joint. they'll flex the knee joint. They'll make the tibia go backwards, and that is flexion at the knee. It is for that reason that we call it the flexor compartment of the thigh. This particular compartment contains 3 major muscles, although I'll add one. So the 3 major muscles are the biceps femoris, called so because it has 2 heads of origin. There's a long head and a shorter head, and they just mean what I've said. One is long, one is short. Then we have semitendinosus, called so because it has a tendinous insertion. It has a long tendinous insertion, so it's called semitendinosus because of the long tendinous insertion. I hope you remember what an origin is and what an insertion is. And then we have semimembranosus because it has membranous origin. So remember, semimembranous is membranous origin. The membrane is proximal near the ischial tuberosity. For the semitendinosus, the tendon is distal towards the tibia. These are the 3 major muscles which are in the posterior thigh. But there's also another part of muscle which you call the adductor magnus. Some part of the adductor magnus is also considered to be in the posterior thigh. But these 3 are the major ones. So what do these muscles do, these 3? These 3 muscles flex the knee joint, hence the name, the flexor compartment. But they also have an action at the hip joint. They attach at the ischial tuberosity, and so they help to extend the hip. If they contract, the thigh will go backwards. That is extension at the hip joint. So they extend the thigh at the hip joint. They flex the leg at the knee joint. That's the action. Which nerve goes to these muscles? The nerves which supply the muscles to the posterior thigh are nerves which are coming from the sciatic nerve. Now, sciatic nerve usually has 2 nerves within that common sheath, the tibial nerve and the common peroneal nerve. So we have branches of tibial nerve going to these muscles. We also have branches of the common peroneal nerve going to these muscles. And I'm going to specify which ones receive which one shortly. This is the sciatic nerve running in the posterior thigh. So it's also a content of the posterior thigh, and it gives branches to the muscles. Some branches come from tibial division, and some branches come from common peroneal division. Before I specify on which one come from where, maybe let me mention about the blood supply to these muscles. We do not see a large artery really running within the compartment, but we see some arteries entering the compartment, but those arteries come from the front. They come from the anterior thigh, then they go through another muscle, which we call the adductor magnus muscle. The arteries which enter the posterior thigh go through the adductor magnus muscle to enter the posterior thigh. Those arteries are called perforating arteries. They are usually 4. So we have the first perforating artery, second, third, and fourth perforating artery. Those arteries are branches of another artery, which is running in the anterior thigh. We call the profunda femoris artery. The term profunda means deep. So the deep femoral artery, profunda femoris artery, gives you perforating arteries. Those perforating branches go through the adductor magnus to reach the posterior thigh, which means that the main artery is not in the posterior thigh, but its branches go through that muscle to reach the posterior thigh. That's what they call the perforating arteries. When they get to the posterior thigh, they supply the musculature of the posterior thigh. Well, they also form an anastomosis around there, which we call the longitudinal anastomosis, but we'll talk about that shortly. When you're talking about the posterior thigh, there's a term called hamstring that we commonly hear. The musculature of the posterior thigh some of them belong to the group that we call the hamstring muscles. Now, the hamstring group of muscles refer to muscles with some common characteristics. And these are the common characteristics. The hamstring unit have the same origin, and the origin is ischial tuberosity. So they all arise from the ischial tuberosity. The hamstring group has the same insertion, and this insertion same in quotes because not exactly same unless you put it in a way that will actually be same, and we can just say bones of the leg. So that will make them same. They all insert the bones of the leg. Having said so, it means that the hamstring group of muscles must traverse two joints. They traverse the hip joint. They also traverse the knee joint. So they must traverse those two joints. Another characteristic is that the hamstring group of muscles have the same innervation. And the innervation here is that they're all supplied by branches of the tibial division of the sciatic nerve. They're all supplied by tibial nerve, basically. The nerve supply is derived from the tibial division of the sciatic nerve, not from the common peroneal. And lastly, they have similar action. They all extend the hip joint and flex the knee joint. So with that kind of description, we notice that all the mass of the posterior thigh may belong to the hamstring group, except the short head of the biceps femoris muscle. And why do we say so? The short head of the biceps femoris muscle originates from the linea aspera. It originates from the femur. It does not arise from the ischial tuberosity. Also, the short head of the biceps femoris is innervated by the common peroneal nerve. It is not innervated by the tibial division of the sciatic nerve, but it's innervated by the common peroneal division of the sciatic nerve. And for that reason, the short head of biceps femoris cannot extend the hip. Yes, it will flex the knee, but it cannot extend the hip. And so the short head of biceps femoris is not part of the hamstring unit. So what are the components of the hamstring group of muscles? We have the long head of the biceps femoris. We have semitendinosus, and we have semimembranosus. Those three are the principal members of the hamstring group of muscles. Long head of biceps femoris, semitendinosus, and semimembranosus. But we can add another one. This muscle we mentioned called the adductor magnus. There's a part of adductor magnus that originates from ischial tuberosity. And that part of adductor magnus is also innervated by the tibial nerve. That part of adductor magnus has a tendinous insertion that goes much down. Well, primarily inserts into the adductor tubercle on the medial aspect of the medial femoral condyle. But because of its origin, ischial tuberosity, and because of its innervation, tibial nerve, because partly of its action of extending the hip, that part of adductor magnus is also considered sometimes to be part of the hamstring unit. So if you're asked to name three components of the hamstring unit, you don't have to mention it. But if you have to mention four, then you have to mention that one. Remember, the short head of biceps doesn't qualify to be a hamstring, but there's a part of adductor magnus muscle that qualifies or may qualify to be a hamstring. Now we can talk about the anterior muscular compartment. The anterior muscular compartment of the thigh refer to the group of muscles which are in front of the thigh. It's the most bulky group, though. It's the largest group. These muscles, which are anterior in the thigh, insert partly some of them into the patella, and so by attaching to the patella, by extension, there's the extension all the way to the tibia. When these muscles contract, they cause extension at the knee joint. Because of their action at the knee, we call this anterior muscular compartment the extensor compartment of the thigh. This group of muscles has many muscles, but among those many muscles is another unit that we call the quadriceps femoris unit. If you remember the concepts which I used in naming muscles, the term quadriceps would mean that there are four heads of origin, and femoris here would mean that found in the thigh region. So there's a group we call the quadriceps femoris unit, which belong to this particular category, and I want to mention the components of the quadriceps femoris unit at this point. We have this muscle here, which we call rectus femoris. It arises from the anterior inferior iliac spine. Then we have three muscles which are wide and flat. We call them the vasti. So this one is called the vastus medialis. This one is called vastus lateralis. And there's another one deep to rectus femoris, which we are not seeing, which we call vastus intermedius. So rectus femoris, vastus medialis, vastus lateralis, and vastus intermedius are the components of the quadriceps femoris unit. Out of those four muscles, only the rectus femoris crosses the hip joint. So the vasti do not cross the hip joint. That means they only act at the knee, but they cannot act at the hip joint. But in principle, they're the ones which mainly cause extension at the knee, and that is why we call this compartment the extensor compartment of the thigh. Other than the quadriceps femoris unit, there are also other muscles which are in this category, in this compartment. This one here is the tensor fascia lata. I'd already mentioned it when you're discussing the iliotibial band. You can see that band there. So this is the tensor fascia lata. Also, we have this one called the sartorius muscle. Sartorius muscle is the longest muscle in the body. It crosses from the anterior superior iliac spine and go all the way to insert onto the tibia, medial aspect of the tibia. So it crosses like that. We also have this muscle here, which we call pectineus muscle, partly in the anterior compartment and partly in the medial compartment as well. And lastly, we have this muscle here, which we call the iliopsoas unit. The iliopsoas unit has two units in one. We have the iliacus and we have the psoas major. So there are two units there. Great. So what are the actions of the muscles of the anterior thigh? The quadriceps femoris unit, in principle, extend the knee joint. So they cause extension at the knee joint. Apart from extending the knee joint, the rectus femoris muscle flexes the hip joint. Pardon, that should be flex the hip joint, not extend. The rectus femoris flexes the hip joint and the whole unit extend the knee joint. Because of the extension of the knee joint, that's why we call the anterior compartment the extensor compartment of the thigh. Quadriceps femoris unit inserts through a common tendon, this one, which we call the quadriceps tendon. And then the quadriceps tendon attaches to the bone there, which we call the patella. Then from the patella, we have a ligament, which we call the patellar ligament, going all the way to the tibia. So the quadriceps femoris unit, quadriceps tendon, the patella, and the patellar ligament constitute what we call the extensor mechanism of the knee joint. We'll revisit that story when you look at topographic anatomy of the knee. Apart from extension at the knee and flexion at the hip, which is contributed by the rectus femoris, the other muscles of the thigh may have some specific actions. For example, tensor fascia lata doesn't quite extend the knee because it doesn't reach there, but it flexes the hip joint. It can also abduct the hip joint. Tensor fascia lata is a muscle that is important to note because it's one of the muscles that inserts into the iliotibial band. Sartorius muscle, on the other hand, is this one here. Sartorius has multiple actions at the knee and at the hip. At the hip, it can cause flexion. It can cause abduction. And it can cause lateral rotation at the hip joints. And at the knee joint, it causes flexion. And it causes medial rotation at the knee joint. So it's a muscle with multiple actions. Remember, it flexes the knee. It does not extend the knee. Iliacus muscle largely flexes the hip joint together with psoas major, which also flexes the hip joint. And these two, the iliacus and the psoas major, constitute a common unit, which we call the iliopsoas unit, perhaps the most powerful flexor of the hip joint, the iliopsoas unit. Pectineus is here. It partly flexes the hip joint and also adducts the hip joint. So those are their unique actions, those other muscles. Now let's talk about their nerve supply. What's the nerve supply of the muscles of the anterior thigh? Most of the muscles that we mentioned are innervated by branches of the femoral nerve. And so we can say that the femoral nerve is the nerve of the anterior muscular compartment of the thigh. However, there are a few exceptions. The exceptions are these ones. So psoas major is not innervated by the femoral nerve. Tensor fascia lata is also not innervated by the femoral nerve. If you remember from the previous session, tensor fascia lata is supplied with the superior gluteal nerve, the same nerve that goes to the gluteus medius and minimus. How about their blood supply? The blood vessels which go to the muscles of the anterior thigh will be either direct and indirect branches from the femoral arterial system. We'll be talking about femoral arterial system towards the tail end of this particular virtual lecture. Now we can talk about the medial muscular compartment. The medial muscular compartment is also called the adductor compartment. This is because of the action that these muscles have on the hip joint. Now hip joint, not knee joint. There are some 5 key muscles in this particular category. We have pectineus again. So that tells you that pectineus is both in the anterior and the medial compartment. We have adductor brevis, we have adductor longus, we have what you call adductor magnus, this particular one, and we have the gracilis muscle. So those 5 muscles are the muscles which belong to the medial compartment of the thigh, which you also call the adductor compartment of the thigh. This one shows you pectineus, adductor brevis, and the gracilis. And this one shows you adductor longus and adductor magnus. The adductor magnus is very extensive from there all the way to here. with that part, you can see the part that I was telling you is the hamstring part, that tendinous part. And then this part from here to there is the adductor part. There's that gap between the two, which you call the adductor hiatus. What are the actions of these muscles? So as the name suggests, the muscles of the medial compartment will cause adduction at the hip joint. So they adduct the thigh at the hip joint. Other than that, there are some muscles with other actions as well. For example, gracilis, apart from adducting the hip joint, may also cause flexion at the knee joint based on its orientation. It may also cause medial rotation of the knee joint, especially of a flexed knee. Indeed, the gracilis, sartorius, and semitendinosus usually have a common insertion. The insertion is a common aponeurosis, which we call the pes and serina. So the gracilis, sartorius, and semitendinosus both insert in a common tendon or a common membrane, which we call the pes and serina. These three muscles are sometimes called the gyropes: gracilis, semitendinosus, and sartorius, the gyropes. They flex the knee joint. Pectineus can flex as well as adduct the hip joint. Adductor magnus has the hamstring part, which can extend the hip, as we mentioned earlier. In terms of the nerve supply, all the muscles of the medial compartment of the thigh are supplied by the obturator nerve. All of them are supplied by the obturator nerve. However, it is important to note at this point. So anyway, this is the obturator nerve. We'll talk about it later again. It is important to note at this point that there are some muscles with the dual innervation. So when you say a muscle has dual innervation, it means there's two nerves supplying it. For example, adductor magnus, because you've mentioned a part of it being a hamstring, being innervated by tibial nerve, and a part of it being an adductor, being innervated by the obturator nerve. So that's why it's having dual innervation. Pectineus also has dual innervation because it's partly in the anterior thigh being innervated by femoral nerve and partly in the medial thigh being innervated by the obturator nerve. So those two are categorically dual innervation. Adductor brevis is contentious. The nerve that goes to adductor brevis is obturator nerve given. However, the obturator nerve has two divisions, the anterior division and the posterior division. So those two divisions both supply the adductor brevis muscle. And that is why we can consider adductor brevis as also having dual innervation. Another muscle that has dual innervation that we didn't talk about, remember, but that was in the posterior compartment, is the biceps femoris, which was having both tibial and common peroneal nerve supply. So that is the muscular compartments of the thigh. Now I want us to look at the anatomical spaces in the thigh. We'll focus on the popliteal fossa, femoral triangle, femoral sheath, and the adductor canal. As we do that, we'll be looking at the site where they're found, the borders of those spaces, the structures which are found within those spaces, and how that is clinically important. We'll start with the popliteal fossa. The popliteal fossa is located behind the knee joint. So it's a diamond-shaped potential space just behind your knee joint. This diamond-shaped space has four walls, just like a diamond. So superomedially, which means superior medial there, as demarcated by that black line, that the superomedial wall is formed by two muscles, semitendinosus and semimembranosus. So those ones are superomedial. The superolateral wall is this region here, and we can see a muscle there, the biceps femoris. And at this point, both the long and the short head of biceps femoris have already fused. So we are talking about the common muscle and the common tendon. Then inferiorly, we also have inferomedial and inferolateral boundary. This is the inferomedial boundary there, being formed by this muscle here. We call it the medial head of the gastrocnemius muscle. So gastrocnemius is a muscle in the posterior leg, but we see it arising from the condyles of femur, and so it's partly forming the boundaries of the popliteal fossa. Usually the gastrocnemius muscle has two bellies, a medial belly and lateral belly. So the lateral belly is the one that will form the inferolateral wall of the popliteal fossa. So you can see this, the diamond-shaped space just behind the knee joint. And so those are the walls of the popliteal fossa. But remember, this is a 3D structure. So you're not just having walls, there's also a roof and a floor. The roof of the popliteal fossa is formed primarily by the popliteal fascia. The popliteal fascia is the extension of the fascia lata over the popliteal fossa. So that's the popliteal fascia. It's the one that forms the roof. However, there are some structures which are found in the subcutaneous tissue of this roof. We can mention a few. We have the small saphenous vein. Look at this. So this is fascia lata. The extension of the fascia lata over the popliteal fossa is what we call the popliteal fascia. On this popliteal fascia, we have the small saphenous vein. It passes through this roof and then even goes through it to terminate into the vein deep to the popliteal fossa, which we call the popliteal vein. We also have the terminal branches of the posterior cutaneous nerve of the thigh. So the posterior cutaneous nerve of the thigh is a superficial vein nerve. Posterior cutaneous nerve of the thigh is a superficial nerve, and its termination is actually over the popliteal fossa there. There's a nerve called serral nerve, which is also partly here. The serral nerve is a cutaneous nerve that branches from the tibial nerve given within the popliteal fossa. So partly, or it may sometimes also pass through the roof. So those are the structures which are found on the roof. But remember, the structure forming the roof is the popliteal fascia, which is an extension of the fascia lata over the popliteal fossa. How about the floor of this space? The floor of this space is formed from above downwards by this part here. That's the popliteal surface of femur. This is the popliteal surface of femur. Remember, we have the medial and the lateral supracondylar lines, which are extensions of the linea aspera. So this space is the popliteal surface of femur. If you go down, then we find the posterior capsule of the knee joint. That posterior capsule of the knee joint is reinforced by a ligament. This ligament here, called the oblique popliteal ligament, is an extension of the insertion of semimembranosus muscle. So semimembranosus muscle comes to insert somewhere there. Then from there, we get some expansion or extension that reinforces the posterior aspect of the capsule of the knee joint. We call that the oblique popliteal ligament. Going down, there's a muscle there called popliteus muscle. This muscle is usually covered by a fascia. So the fascia that covers popliteus muscle is also part of the floor of the popliteal fossa. Those are the structures which form the floor of the popliteal fossa. So that's the fossa with the walls. What are the structures found within the fossa? The contents. Here we have the terminal branches of the sciatic nerve, the terminal branches of the sciatic nerve. This terminal branch of the sciatic nerve are two. We have the tibial nerve, which is this one, and you have the common peroneal nerve, which is that one. Usually the tibial nerve runs almost in the middle of the fossa, but the common peroneal nerve runs in the superolateral wall of the fossa, just next to the biceps femoris. The branches that these nerves give are also contents of the fossa. So which branches do these nerves give? The common peroneal nerve gives some cutaneous branches within this fossa, but it also gives some articular branches within this fossa. The cutaneous branches that the common peroneal nerve gives within this fossa are two. We have what we call the serial communicating nerve, which is a branch of the common peroneal nerve that joins the serial nerve. And we have the lateral cutaneous nerve of the calf. So the lateral cutaneous nerve of the calf is given within the fossa and comes like this. This is the lateral cutaneous nerve of the calf. And then you have the serial communicating nerve, which is this one. The serial communicating nerve joins the serial nerve, which come from the tibial nerve. So those are cutaneous branches of the common peroneal nerve within the fossa. Apart from the cutaneous branches, we also have articular branches. The articular branches go to the knee joint. We have what we call the superior lateral genicular nerve, and we have the inferior lateral genicular nerve. So superior lateral genicular nerve and inferior lateral genicular nerve are also articular branches of the common peroneal nerve given within the fossa. How about the branches of the tibial nerve given within the fossa? The cutaneous branch of tibial nerve given within the fossa is the serial nerve. So serial nerve comes from the tibial nerve, and serial communicating nerve comes from the common peroneal nerve. Sometimes that terminology or naming system is variable in different books. Some books will talk about medial serial nerve coming from the tibial nerve, and the lateral serial nerve coming from common peroneal nerve, and the two join to form serial nerve. So that's one naming system. The other naming system is that serial nerve is a branch of the tibial nerve, and then the one that comes from common peroneal nerve to join it is called the serial communicating nerve. It is okay to familiarize with both naming systems because they're both correct. Apart from the cutaneous branch that come from tibial nerve, we also have articular branches from the tibial nerve. The articular branches from the tibial nerve go to the knee joint. There are three. We have superior medial genicular nerve. We have middle genicular nerve, and we have inferior medial genicular nerve. So those are articular branches of the tibial nerve to the knee joint. Superior medial, middle, and inferior medial genicular nerve. Then finally, we have muscular branches of the tibial nerve given within here. The muscular branch of the tibial nerve given within here are largely the ones which go to the gastrocnemius muscles, as well as the one that go to the another muscle there called popliteus muscle. Great. So the branches, the terminal branch of the sciatic nerve and their branches are contents of the popliteal fossa. Apart from that, we have the popliteal artery and its branches within the popliteal fossa. The popliteal artery is the most anterior neurovascular structure. And the most anterior neurovascular structure in the popliteal fossa will also therefore qualify to be the deepest structure in the popliteal fossa. That means that this is the neurovascular structure that makes contact actually with most parts of the popliteal surface of femur, capsule of the knee joint, and also the fascia over popliteus. It's the one next to the floor. So it's the deepest or the most anterior structure in the popliteal fossa. It also gives multiple branches. Some are muscular branches, especially the ones which go to the gastrocnemius. We call them serolateries, actually. Those are muscular branches to the gastrocnemius muscle, serolateries. We also have branches which supply the knee joint and contribute to what we call the genicular anastomosis. They have similar names like the articular branches of the tibial and common peroneal nerve because they accompany those nerves. So we'll have superior medial genicular, we'll have superior lateral genicular, we'll have middle genicular, we'll have inferior medial genicular and inferior lateral genicular. In this particular image, you can see the popliteal artery there. So there's inferior lateral genicular artery. We have inferior medial genicular artery. We have superior medial genicular artery. We have superior lateral genicular artery. And we have middle genicular arteries as well. The middle genicular arteries may be double, maybe two of them. So those 5 or 6 genicular arteries are articular branches of the popliteal artery. Remember, for the arteries, all the 5 come from the same artery. But for the nerves, tibial gives you 3, the ones with the M, and common peroneal gives you 2, the ones which are lateral. But they accompany each other. They are neurovascular bundles. So those are the genicular branches of the popliteal artery given within the popliteal fossa. Those arteries contribute to anastomosis around the knee joint. We have the popliteal vein and its tributaries. Popliteal vein is usually on top of the popliteal artery, then tibial nerve on top of the popliteal vein. So it's artery, vein, then nerve, from deep to superficial or from anterior to posterior. The branches or the tributaries of the vein will accompany the branches of the artery, and they have similar names. The only exception is that the popliteal vein also receives the small saphenous vein. Small saphenous vein terminates within the popliteal fossa. So this image shows you the small saphenous vein as it terminates into the popliteal fossa. It will terminate into the popliteal vein within the fossa. So it will have to go through the roof of the popliteal fossa. That's why we say it's partly in the roof and partly not in the roof. Remember, the small saphenous vein comes from the lateral aspect of the foot and then posterolateral calf, and it will have accompanying lymphatic vessels, superficial lymphatics, which run with it. We also have a pad of fat or extensive fat that is contained within the popliteal fossa. And then within that fat, we have several lymph nodes as well, popliteal lymph nodes. The popliteal lymph nodes could be both superficial and deep, that those that are within the fossa, and that those which are superficial. They are all called popliteal lymph nodes. The superficial ones accompany the small saphenous vein generally. So what's the clinical importance of the popliteal fossa? Maybe before I go to the clinical importance, you can see in this particular image what is called seronerve, and how it's formed by 2 nerves, one from the common peroneal. So in this one, it's being called the lateral seronerve. You can also call it serocommunicating. And then this one is called the medial seronerve. It can still be called the seronerve. So this is tibial nerve. That's sciatic nerve giving you common peroneal nerve, also called common fibular nerve, common peroneal nerve, and tibial nerve. Tibial nerve is giving you seral nerve, or in this context, being called medial seronerve, so that the other one is being called lateral seronerve to constitute the seronerve. Then this is the small saphenous vein terminating into the popliteal vein. You can see fat there, and these two are the gastrocnemius muscles. So what's the clinical importance of the popliteal fossa? Occasionally we see a number of swellings within the popliteal region. When you see swellings in the popliteal region, like that one, what could it be? Maybe the popliteal artery is the one that is swollen, ballooning out because of weakening of blood vessel wall. We call that aneurysm. Maybe it's the fat that has become, it's overgrown. Benign tumors from fat are called lipomas. Maybe it's the lymph nodes which are swollen because of some infection. You may call that lymphadenopathy. Or maybe it's the synovial membrane of the knee joint popping out through the popliteal fossa. We call that Becker cyst. These are the common causes of swellings within the popliteal fossa. The next anatomical space I want to talk about is the femoral triangle. Femoral triangle is located in the proximal anteromedial thigh. So it's an inverted triangle, inverted to mean that the base is superior and the apex is inferior. It's an inverted triangle in the proximal anteromedial thigh. The upper part of the thigh, anteriorly and medially. That's the location of the femoral triangle. So what are the boundaries? We'll expect it to have 3 walls, and then a roof and a floor. The superior boundary, which is called the base of the triangle, is this one here, formed by the inguinal ligaments. The medial boundary, which is this one here, is formed by the medial margin or the medial border of the adductor longus muscle. This one labeled AL is the adductor longus muscle. This one is pectineus. This one is sartorius. This is iliopsoas unit. So the medial border, remember medial border, not lateral border, but medial border of the adductor longus muscle is the medial boundary of the triangle. Then the lateral boundary of the triangle is also the medial border. So both are medial borders of sartorius, medial border of adductor longus. The medial border of sartorius is the lateral boundary of the femoral triangle. How about the apex? So the apex is down here. The apex is the union of the medial and the lateral border. The apex of the femoral triangle continues into another space, which we call the adductor canal. So if this is the lateral border, that's the medial border, they meet somewhere here. And so this is the apex of the femoral triangle, which continues into what we call the adductor canal. This one here is the adductor canal. We'll talk about it shortly. The floor of the femoral triangle is formed by some muscles. We can name them from medial to lateral. So from medial, we have the adductor longus muscle. So I've changed that so that we can be able to see the pointer well. So this is the adductor longus muscle. Then from there we have this, that's the pectineus muscle. And then from there we have this unit here, which we call the iliopsoas unit. The iliopsoas unit has 2 parts, the psoas major and the iliacus. So we usually start from the psoas major is medial and the iliacus is lateral. Those 4 muscles or 3 muscles are the ones which form the floor of the femoral triangle. Then we have the roof of the femoral triangle. The roof of the femoral triangle is formed by the fascia lata. and the cribriform fascia. We had already mentioned what is fascia lata and what is cribriform fascia. So basically, the deep fascia of the thigh is fascia lata, but it has a defect somewhere there, which we call the saphenous opening, over which we are going to have the cribriform fascia. So those are the ones which form the roof of the femoral triangle. However, within this roof, we have some various structures in the subcutaneous tissue. We had already mentioned them. The termination of the great saphenous vein, the superficial inguinal lymph nodes, both the transverse and the vertical group. And then some superficial veins as well that terminate into the great saphenous vein, like the superficial the superficial circumflex superficial epigastric, and superficial externopudental, as shown in that particular image. They're also on the subcutaneous tissue. Those are the boundaries of the femoral triangle. So what are the contents of the femoral triangle? The femoral triangle contains the femoral nerve and its branches. So this is the femoral nerve. It is contained within the femoral triangle and its branches. The femoral nerve has several branches, very many branches. As we can see here, it ramifies into many branches. These branches can be classified as muscular, which means they go to muscles, and the muscles here are the muscles of the anterior thigh. Some of the muscular branches may be named, like the one which goes to the vastus medialis. We call it nerve to vastus medialis. Apart from muscular branches, we also have cutaneous branches. The cutaneous branches are the ones which go to the skin. Again, there are many. As we had mentioned earlier, they are the ones which give you the branches which go to the anterior thigh. So the intermediate cutaneous branch of the thigh and the medial cutaneous nerve of the thigh, they're all branches of the femoral nerve. Apart from that, the termination of the femoral nerve is a long sensory nerve, which we call the saphenous nerve. This one is the termination of the femoral nerve. It's a long sensory nerve. It runs all the way to go even on the middle aspect of the knee, middle aspect of the leg, all the way to the middle aspect of the foot. Very long. That's the termination of the femoral nerve, called saphenous nerve. It's a cutaneous nerve. Apart from femoral nerve, we also have the femoral arterial system and their branches. When you talk of femoral arterial system, we are referring to three major arteries. We have what we call the common femoral artery, which comes like that. And that common femoral artery is an extension of the external iliac artery. So the external iliac artery gives you the common, continues as the common femoral artery below the inguinal ligament. So when it's above the inguinal ligament, you call it external iliac artery. But below inguinal ligament, call it common femoral artery. Let me change that pointer so that you can see that well. So this is the external iliac artery, which becomes common femoral artery. The common femoral artery divides into two within the femoral triangle. We have this one, which has been cut. We prefer calling superficial femoral artery. And then this one, what we call the deep femoral artery. So the common femoral artery, the superficial femoral artery, and the deep femoral artery are the components of the femoral arterial system. And those three arteries are partly within the femoral triangle. The branches which come from them, and especially the branches which come from the common femoral as well as the deep femoral, are also partly contained within the femoral triangle. We'll talk about those branches shortly when we look at the artery itself in great detail. Then you have femoral veins and its tributaries. So the femoral vein is the vein that accompany the femoral arterial system. They have similar names. The only thing I want to add is that remember the femoral vein, and in this case the common femoral vein, is the one that receives the great saphenous vein. So the termination, the greater venous vein, is also within the femoral triangle. We have lymph nodes which are within the femoral triangle. Those lymph nodes are now called deep inguinal lymph nodes. They run along the femoral vessel, the femoral artery in particular. These deep inguinal lymph nodes receive all the lymph nodes from the lower limb. We can say that because it will receive even the superficial inguinal lymph. The lymph from the superficial inguinal nodes enter the deep inguinal lymph nodes. We have the femoral branch of the genitofemoral nerve. It's a small nerve that runs with the femoral artery and supplying the skin over the over the femoral triangle. The skin of the femoral triangle is supplied by the femoral branch of the genitofemoral nerve. So it's partly contained within that particular space. What's the clinical importance of the femoral triangle? We can mention a number of things. One is swellings that we sometimes see within the femoral triangle. They could be because of what we call inguinal lymphadenopathy. The lymph nodes are swollen, but could also be because of what we call femoral hernias. I'm going to talk about femoral hernia shortly. We can also feel the pulsations of the femoral artery. In this case, the common femoral artery. We usually feel it at what we call the mid-inguinal point. This is a midpoint between the pubic tubercle and the anterior spherical spine. That's the midpoint. So that will take you to the inguinal ligament. So just below that is where you find the pulsations of the femoral artery. And the reason why you want to get pulsation of the femoral artery could be multiple. One could be that you want to estimate where the vein is so that you can perhaps withdraw some blood sample from the vein. But could also be that you want to put an instrument through the femoral artery itself for cardiovascular intervention. So there are multiple reasons why you may want to do the pulsations of the femoral artery. Great. That's just to capture some of the clinical importance of the femoral triangle. But let me go slightly deeper and talk about something within the femoral triangle. That is what we call the femoral sheath. The femoral sheath is a common connective tissue sheath that surrounds the common femoral vasculature. This connective tissue sheath is usually a continuation from the fascia that come from the abdomen. As the blood vessels, the common femoral vasculature enter the thigh from the external iliac vasculature, they extend into the thigh together with their connective tissue covering. And so some fascia of the abdomen extend with them into the thigh. We see that common connective tissue sheath that cover the vessels. We call that the femoral sheath. Take note that the nerve is not within that sheath. The femoral nerve is also the sheath. So here we're just talking about the vessels. So which fascia of the abdomen actually form the femoral sheath? There are two fascia of the abdomen that form the femoral sheath. We have what we call the fascia iliacus. So that's the fascia that cover the iliacus muscle. That will form the sheath from the posterior perspective. And then you have what you call fascia transversalis. Fascia transversalis is the one that forms the femoral sheath anteriorly. So femoral sheath is formed by fascia transversalis anteriorly and fascia iliacus posteriorly. The sheath is not that long, by the way, maybe just 3 to 4 centimeters, or could be even as short. Now, the femoral sheath is divided into some compartments. And these compartments have some specific contents. In particular, it is divided into 3 compartments using some 2 septa. So there's a septum here, and there's a septum there that divides the femoral sheath into 3 compartments. The lateral compartment of the femoral sheath is the one that contains the femoral artery, this one. It also contains the femoral branch of the genitofemoral nerve. So in this image, we see the lateral compartment there having the femoral artery and the femoral branch of the genitofemoral nerve. Then we have the intermediate compartment here, which contain the femoral vein. Now, this would be the common femoral artery, common femoral vein. The medial compartment is worth noting. The medial compartment is actually just a potential space. This potential space is called the femoral canal. I want us to talk more about the femoral canal, but this is it. So this is the femoral canal, that potential space. This is the intermediate space with the common femoral vein, and this is the lateral compartment with the common femoral artery and femoral branch of genitofemoral nerve. Remember again, the femoral nerve itself is not within the sheath. This is the sheath. In this image, you can see that the femoral canal has some lymph nodes. Talking about that shortly. So this is the cross-sectional anatomy of the femoral sheath with the contents. Lateral compartment, common femoral artery, and femoral branch of genitofemoral nerve. Middle compartment, femoral vein, and medial compartment is called the femoral canal. Within the femoral canal, there's a lymph node. They are part of deep inguinal lymph nodes. We call it the deep inguinal lymph node, or the node of Cloquet. This particular lymph node is the one that drains the glans clitoris and the glans penis. So the tip of the clitoris and the tip of the penis drained by this particular lymph node. On this image, you can see that is the inguinal ligament. And this is the lacunar ligament. Pectineal ligament extends posteriorly there. So this is the region of the sheath, the artery, lateral vein in the intermediate, and this is the region of the femoral canal, but has loose connective tissue. So it's a potential space. Now let's talk about the femoral canal itself. We are narrowing down to the canal. So the canal is that potential space on the medial compartment of the femoral sheath. This canal has some boundaries. We can say on the lateral aspect, it is separated from the common femoral vein by that septum. On the middle aspect, it is bounded by the lacunar ligament. On the posterior aspect, is separated from the pectineous muscle by the fascia that covers pectineous muscle, and also by the pecten pubis. So basically the superior pubic ramus. And anteriorly, it's bounded by the inguinal ligament. So that is the femoral canal. Remember, it's an extension, it's a canal. In that region, that's a cross-section of it. So that's the region. Inguinal ligament, lacunar ligament, pectineal ligament somewhere. Related to the femoral canal is what we call the femoral ring. The femoral ring is the proximal opening, the abdominal mouth of the femoral canal. If the canal is along it, it's a tubular thing, the proximal mouth of that tube is what we call the femoral ring. So here, while the whole of this is the canal, only this one is the ring. The proximal mouth of the canal is the ring. This proximal mouth of the canal is bounded still by almost similar things, but we'll have to specify a few. Especially on the posterior aspect now, we'll have to specify the pectineal ligament in the posterior aspect. Now it can't be the fascia covering pectineous muscle, but the pectineal ligament itself. The others will remain the same. Now, why are we insisting on you knowing the boundaries of the femoral ring? Because of its clinical implication. Okay, maybe this image captures for you that femoral ring. This is the mouth now, so we'll expect the inguinal ligament to be there, lacunar ligament to be there, and the extension of this one is the pectineal ligament there. Those are the boundaries of the ring, which is the proximal mouth of the canal. The importance of knowing those bounds because of its clinical perspective, that this ring is the site of occurrence of inguinal herniations. So at this point, then we can define what's hernia. A hernia is protrusion of an organ or tissue through a defect. In this case, some tissues or organs within the abdominal cavity may protrude through this defect into the thigh. And so we call that femoral hernia. So this is where femoral hernias occur. There are different types of hernias. For femoral hernias, they occur through the femoral ring, which means some abdominal tissue protrude to go towards the thigh. And that can be painful. Now, femoral hernias are more common in females than males. And there's some two anatomical reasons for that. Others could be physiological, but let's focus on the anatomical reasons. So one of the anatomical reasons, if you are to have the sheath as a constant, then you put blood vessels inside that sheath. Females usually have smaller blood vessels compared to males. And so if the size of the sheath was constant and you put two small blood vessels there, it means that the potential space will be bigger in female than in males. And that's one of the reasons, because the smaller blood vessels. The second reason why femoral herniations will be more common in females than males is because generally the females have a wider pelvis. And so basically it means that the sheath will be potentially larger, therefore, in female compared to males. So the wider pelvis, hence a wider canal. Those are the two anatomical reasons we can give why femoral herniations are more common in females than males. Please do not confuse femoral herniations with what we call inguinal herniations. The inguinal hernias occur at a different site from what we've underlined. And inguinal hernias are more common in males than females. Actually, inguinal hernias are the most common hernias anyway. If you have to compare inguinal and femoral, inguinal hernias are more common, and they're also more common in males and females. Don't confuse them. The last space I want us to discuss is what we call the adductor canal. The adductor canal is located within the thigh, almost in the middle third towards the lower part. It's located in the anteromedial thigh, almost middle third. It's an intermuscular tunnel, which means it's within muscles. It's also called the subsartorial canal because it's found below the sartorius muscle. Also called the Hunter's canal in respect of the person who described it. It extends from the apex of the femoral triangle superiorly all the way to the adductor hiatus, that opening that was within the adductor magnus muscle, adductor hiatus. So this is the apex of the femoral triangle. This is from where it extends, apex of the femoral triangle superiorly, all the way to the adductor hiatus. It will extend up to that region. So the canal falls somewhere here. From the adductor hiatus, it communicates the popliteal fossa through the adductor hiatus. So that is the adductor canal. What are the boundaries of the canal? For us to understand the boundaries well, it will be important to understand that it's just below the sartorius muscle. So that sartorius muscle usually forms the roof of the canal, or if you look at it in cross-section, then it forms the medial wall or the anteromedial wall. This is the sartorius muscle, but let me give you a cross-section so that you can see. So this is a cross-section through the thigh. That is the adductor canal, the space we are concerned about. So the muscle level B there is the sartorius muscle. If this is anterior side, this is posterior side. This is medial side, this is lateral side. This sartorius muscle is on the medial wall, or it is on the anterior medial wall. And that is basically the roof of the adductor canal. Then we have the lateral wall, which is this one here. We can see that is also qualifying to be called the anterolateral wall. And the muscle we see there is that muscle there, vastus medialis. Do not confuse it with vastus lateralis. Yes, lateral wall, but vastus medialis. See, vastus lateralis is somewhere here. And this is vastus intermedius. This is vastus medialis, and this is rectus femoris. So the vastus medialis is the muscle of concern here. Then the posterior wall will qualify also to be called the floor. The floor is formed by adductor longus muscle, the one labeled D, and this will be true for the upper parts of the canal. But as we move down, after the adductor longus muscle has already inserted, the muscle that remains to be still forming the floor of the tunnel is this one here labeled E, which is the adductor magnus. So the floor of the posterior wall is formed by two muscles, adductor longus on the upper part and adductor magnus in the lower part. This image captures for you that concept. You see the adductor longus muscle there. Let me change the pointer a bit for you to see it better. So this is the adductor longus muscle, terminate somewhere. Then we see adductor magnus still extending down. So the upper part of the tunnel will be formed by adductor longus on the floor, but the lower part of the floor will be formed by adductor magnus. So those are the key structures which are on the boundaries, but occasionally you can hear something on the roof. Usually the sartorius muscle is not so much direct. There's usually some fascia separating it from the tunnel. And that subsartorial fascia may have some nerve plexus around it. Commonly we talk about subsartorial nerve plexus. You can check on which cutaneous nerves or which sensory nerves make that plexus of nerves. These are plexus of sensory nerves, not motor nerves. What are the contents? There's some contents which are vascular. The blood vessels which form within this tunnel are the superficial femoral artery and the superficial femoral vein. Then we have nerves. Which nerves are within this tunnel? We have the saphenous nerve, which is the terminal branch of the femoral nerve. It passes through that tunnel as it goes to the leg. We also have the nerve to vastus medialis, also a branch of the femoral nerve that goes to vastus medialis. Then you have a small twig from the obturator nerve. It's also a content of this particular canal. Those are the contents of the adductor canal. And so that summarizes the story of the anatomical spaces within the thigh. I want us to now summarize by looking at the neurovascular structures in the thigh. I'll start with the arterial system. So I'll just follow for you, but the best thing is that you also just look at an atlas and see it. And also when you go to your lab practical session, again, you appreciate them from the specimens. Let's start the story from up here. So we have a large artery that comes from the heart, we call the aorta. When the aorta comes much down in the abdomen, it divides into two. We have the right and the left common iliac arteries. So the common iliac arteries are designated to go to either side of the body. This common iliac artery divides into two major branches. There's one called the external iliac artery, and there's one called internal iliac artery. The internal iliac artery give you branches which supply the structures within the pelvic cavity. And that's what's called internal iliac, the inside of the ilium. This internal iliac artery is the one that will give you some of the arteries that we mentioned in the gluteal region. Internal pudendal artery, superior gluteal artery, and inferior gluteal artery. So yes, it supplies structures within the pelvic cavity, but some of its branches may go out into the gluteal region to supply structures in the gluteal region. Now, that is not thigh. The artery that goes to the thigh will be the one that we are calling the external iliac artery. So that goes down, and beyond the inguinal ligament, the external iliac artery become now what we call the common femoral artery. That is what we see within the femoral triangle, common femoral artery. The common femoral artery has two major branches, one deep and one superficial. And this image captures that well. So this is the common femoral artery dividing into two, the superficial femoral artery and the deep femoral artery. The deep femoral artery is the one called profunda femoris artery. So common femoral, deep femoral, and superficial femoral artery constitute the femoral arterial system. Now, the common femoral artery may give you some branches before that terminal division. The branches it gives you would be the superficial arteries that go around this region. So we have the superficial epigastric artery, superficial external pudendal artery, the deep external pudendal artery, the superficial circumflex iliac artery. Those ones are given from the common femoral artery. There are four that I've mentioned for you: superficial circumflex iliac, superficial external pudendal, deep external pudendal, and superficial epigastric. They are given from the common femoral artery. Where they go is suggested by their names actually, so no big deal. Now, in this image, you can see the deep circumflex iliac, and you can also see the inferior epigastric artery. Those ones are usually given before the inguinal ligament is closed, and so as a concept, they are branches of the external iliac artery and not branches of the common femoral artery. But the other four I've mentioned are given below the inguinal ligament, and so they are branches of the common femoral artery. After the common femoral artery is divided into two, the superficial femoral artery does not supply many things within the thigh, really. So it's largely an artery that just passes through, supplying minimal, except perhaps just before it terminates, just before it enters through the adductor hiatus, that it gives you this descending genicular branch. So the descending genicular branch is a branch of the superficial femoral artery just before the artery disappears through the adductor hiatus together the superficial femoral vein. Remember, when it disappears through the adductor hiatus, it becomes the popliteal artery that we'd already talked about. But there's much story in the deep femoral artery. The deep femoral artery, which we also call the profunda femoris artery, is the main artery that supplies the structures in the thigh. So this is the main artery of the thigh. It supplies the structures in the thigh. It gives you a number of branches. Important to note are two arteries which go around the femur, and so we call them the circumflex femoral arteries. There's one that goes on the lateral aspect, So we call it the lateral circumflex femoral artery. And there's one that goes on the middle aspect. So we call it medial circumflex femoral artery. Either one or both of the circumflex arteries can come from either the profunda femoris artery or the common femoral artery, and that is a normal variation. So sometimes the medial circumflex may come from common femoral and lateral circumflex from the deep femoral, or the lateral circumflex may come from common femoral and medial circumflex from the deep femoral, or both come from common femoral, or both come from deep femoral. So either one or both may come from either common femoral or deep femoral. Remember, I didn't say superficial femoral. The lateral circumflex femoral artery has some branches, many of them, but we divided them largely into three: the ascending branch, the transverse branch, and the descending branch. The ascending branch goes to the trochanteric anastomosis. We mentioned it in the previous session. The transverse branch goes to the cruciate anastomosis. Again, we mentioned it in the previous session. The descending branch goes to the genicular anastomosis. That's the anastomosis around the knee joint. Of course, they still give you multiple branches even as they do that. The medial circumflex femoral artery gives you an ascending and a transverse branch. The ascending branch again to the trochanteric anastomosis, and the transverse branch to the cruciate anastomosis. We rarely talk about a descending branch from the medial circumflex femoral artery. The main trunk of the profunda femoris artery gives you branches which go through adductor magnus to supply the posterior compartment of the thigh. That's why we call them the perforating arteries. So we have the first, second, third, and fourth perforating artery. The fourth perforating artery being the terminal branch of the profunda femoris artery. The perforating arteries go through adductor magnus to go to the posterior compartment of the thigh, where they supply the muscles of the posterior compartment, largely the hamstring group. They also communicate with one another to form what we call the longitudinal anastomosis. So beyond that, we've talked about the arteries of the thigh. Remember, the superficial femoral artery continues through the adductor hiatus as the popliteal artery. And I'd already told you the branches of the popliteal artery within the popliteal fossa. So we don't have to repeat that one. Maybe just to mention that beyond this one, the popliteal artery will divide into two: the anterior and the posterior tibial arteries. Those are the arteries in the leg, and we'll discuss them when we talk about the leg. So just to take note of some anastomosis that I've highlighted, we have trochanteric anastomosis in the gluteal region formed by superior gluteal artery, ascending branches of the medial circumflex, and ascending branch of the lateral circumflex. The inferior gluteal also contribute that anastomosis. Cruciate anastomosis located at the level of the lesser trochanter. Remember, trochanteric at the level of the trochanteric fossa. Cruciate anastomosis at the level of the lesser trochanter formed by the transverse branches of the circumflex arteries. Then a descending branch from the inferior gluteal and the ascending branch from the first perforating artery. Then we have what we call the longitudinal anastomosis located at the back of the thigh, formed by the perforating arteries. First to fourth perforating artery contribute to that anastomosis. However, we may also have an anastomotic branch from the popliteal artery also joining that anastomosis. Apart from that, we also have anastomosis around the knee joint. We call it genicular anastomosis, but I'd prefer to talk about genicular anastomosis when we discuss the topographic anatomy of the knee joint. This is because there are many other arteries from the leg that will have to come back, and so we've not mentioned them. So let's discuss that genicular anastomosis when we discuss the knee joint. Great. So those are the major vessels. I'll now talk about the major nerves of the thigh, even as we near the finishing line. I'll start with the sciatic nerve. Remember, the topographic anatomy that we expect to highlight when we talk about a nerve still remains. So where does sciatic nerve begin? Sciatic nerve arises from the lumbosacral plexus with the root value L5 to S3, as we mentioned in the previous session. Where does it pass? The sciatic nerve enters the gluteal region below piriformis. That's the infrapiriformic compartment of the greater sciatic notch. After it has entered there, it passes deep to the gluteus maximus muscle, but that will be posterior to the other 6 small lateral rotators if you exclude piriformis muscle. So it passes posterior to the gamellae, the 2 obturator internus, quadratus femoris, and obturator externus. It also passes posterior as well to the knee, the hip joint, as you can see in this particular image. The nerve is behind the hip joint. It will exit the gluteal region by passing somewhere midpoint between the greater trochanter and the ischial tuberosity. So somewhere midpoint, that's a landmark in the gluteal region actually. So this is the ischial tuberosity, and that's the greater trochanter. So somewhere almost midpoint, that's where the nerve passes as it enters the thigh. Now, when it enters the thigh, it enters the posterior compartment of the thigh, deep to the hamstring group of muscles, and especially deep to the long head of biceps femoris muscle. The nerve goes all the way to the apex of the popliteal fossa, where the nerve eventually separates into the 2 divisions. The tibial division going almost straight through the popliteal fossa, and the common peroneal division taking an almost lateral tangent, so running on the superolateral wall of the popliteal fossa. That's the course of the sciatic nerve. The blood supply to the sciatic nerve, we'd already mentioned, it's blood supply in the gluteal region, the companion artery from the inferior gluteal artery. Within the back of the thigh, it is supplied by branches which come from the longitudinal anastomosis. Remember, the longitudinal anastomosis is formed by the union of the perforating branches of profunda femoris. So what's the distribution of the sciatic nerve? The tibial division of the sciatic nerve supply the hamstring group of muscles. Remember, that will include also the hamstring part of the adductor magnus muscle. The common peroneal division of the sciatic nerve goes to the short head of biceps femoris muscle. That is in the back of the thigh. So I've not included the ones we'd already mentioned in the popliteal fossa, but remember them as well. I'm trying to focus on the main composite, the sciatic nerve itself. Remember, there are 2 nerves within one sheath. And so even if you're talking about branch sciatic nerve, they'll be coming from either the tibial division or the common peroneal division. But the branches within the popliteal fossa, usually the sciatic nerve has already separated definitely. And so we can't talk about sciatic nerve at that point. The 2 terminal branches, tibial division and common peroneal division, are responsible for supplying many things within the popliteal fossa, as I mentioned, and also in the leg and the foot. And that is why if you injure sciatic nerve, therefore here, you affect the lower limb significantly. You can paralyze the lower limb. The only things you may not paralyze is basically the muscles, the anterior thigh and medial thigh, but everything else affected. Even sensory, a large part of the lower limb is affected. So that's the sciatic nerve. The other nerve I want to talk about is the femoral nerve. The femoral nerve arises from the lumbar plexus. So this is the lumbar plexus of nerves with the root value L2, L3, L4. However, there's a rider to this. The femoral nerve is formed from the posterior divisions of the ventral rami of L2, 3, 4 nerves. Now, I've said many complex things that for the first time, let me clarify. When a spinal nerve comes out from the spinal cord, usually there are two routes. If this is the spinal cord in cross section, this is the anterior part, this is the posterior part. Okay, let me change that point again. Okay, so this is the spinal cord. There are usually two routes. This is the anterior part, this is the posterior part. So this one here is called the ventral root of a spinal nerve. And this is called the dorsal root of a spinal nerve. The ventral root of a spinal nerve has motor functions. So this is the one that goes to muscles and glands, efferent function. The dorsal root of a spinal nerve has a sensory function. So these are sensory nerves entering the spinal cord. The two roots usually meet, and where they meet is what we call now the spinal nerve. There's usually a small swelling related to the dorsal root, and that's what we call the dorsal root ganglion. It contains cell bodies of the sensory nerves entering the spinal cord. Anyway, the whole of that is called the spinal nerve. A spinal nerve has two rami. The term ramus means branch. So there's a dorsal ramus, which goes posteriorly. Dorsal is posterior in this case. And there's a ventral ramus. The nerves that are usually from the dorsal ramus don't form plexuses. So they're just segmental. They're largely supplying the region of the back. So your back largely is supplied with the dorsal ramus. But the ventral rami contain nerves which usually intermingle a lot. And especially the regions of the limbs, they intermingle to form plexuses. The plexus that go to the lower limb is called lumbosacral plexus, formed by the lumbar plexus and the sacral plexus. So because you're looking at nerves which go to the lower limb here, the ventral rami will form plexuses. Now, the ventral rami further divides into two divisions. We have an anterior division and a posterior division of the ventral rami. So remember the ventral rami, the ones which form the plexuses, and we can see here, these are plexus of nerves. From L1 nerve, L2 nerve, all the way to L5 nerve, we can see these are plexuses, intermingling without synapsing. These are plexuses formed from the ventral rami of those segments. So these ventral rami have, again, anterior divisions and posterior division. The femoral nerve is formed from the posterior division of the spine, the ventral rami L2, L3, and L4. So I hope that brings into perspective what I was telling you. Now let's talk about the cause of the femoral nerve. The femoral nerve enters the thigh deep to the inguinal ligament. Now, as it enters the thigh deep to the inguinal ligament, follow it. So there's the femoral nerve. The nerve actually is found between the groove, within the groove between iliacus muscle and psoas major muscle. So it enters, passes through that groove, and so this is the femoral nerve. Take note that the femoral nerve is not found within the femoral sheath. It is lateral to the femoral sheath. Once it enters the thigh, the nerve divides almost immediately. It ramifies into many branches. So basically, that's the cause. What are the branches? Some of these branches are muscular branches. They go to the muscles of the anterior compartment of the thigh, the extensor compartment of the thigh. So you just call the muscular branch to this, muscular branch to this. But remember, the one that goes to vastus medialis is called nerve to vastus medialis. It's one of the muscular branches named. Apart from the muscular branches, you also have cutaneous branches. These are the ones which go to the skin. So in this image, the blue region represents the territory of those branches. They largely go to the anteromedial skin of the thigh, but also go to the medial side of the leg and foot. So what are the names of these branches? We have the anterior cutaneous branches from the femoral nerve. Remember, there's the intermediate, and then there's the medial cutaneous nerve of the thigh. So there are branches eventually of femoral nerve. But then the terminal branch of the femoral nerve is called the saphenous nerve. It's a long nerve responsible for supplying the skin of the lateral leg and the lateral foot. So that's the distribution of the femoral nerve. Think about it then. If you injure femoral nerve, how will that present clinically? Think about that as a clinical relevance. Apply it. And you can try to injure it somewhere there, in that gutter between the iliacus and psoas major. Think about what will happen. Which regions will lose sensation? Which movements will this patient not be able to perform? As you think through that, remember there's some muscles with dual innervation, so they can actually help in some functions. The last nerve is the obturator nerve. Obturator nerve is also originating from the similar root value like that of the femoral nerve, but there's a difference. Femoral nerve was from posterior division. Obturator nerve is from the anterior divisions of the similar root value. So this is what forms the obturator nerve. Occasionally, you may have an accessory obturator, sometimes not there. So let's just talk about the obturator nerve itself. With the root value L2, 3, 4, anterior division, the obturator nerve runs within the pelvic cavity, as you can see there. It runs within the pelvic cavity. It then passes through the obturator foramen. Remember, the obturator foramen is covered by obturator membrane, but there's a small opening on the upper part, which you call the obturator canal. So the nerve passes through the obturator canal to enter the medial aspect of the thigh. This is the obturator foramen, this is obturator membrane, and that's the obturator canal. So the nerve passes through the obturator canal there to enter the medial aspect of the thigh. And so this is the obturator nerve. The nerve supplies the muscles on the medial compartment of the thigh. Now, the nerve divides into two divisions around the obturator canal, or just before there. We have the anterior division and the posterior division. The anterior division of the obturator nerve goes to obturator externus muscle, adductor magnus muscle, adductor brevis muscle. That's the motor distribution or the muscular distribution. The sensory distribution goes to the knee joint. The anterior division of the obturator nerve is the one that now supplies most of the other adductor muscles of the thigh. In addition to that, it also supplies the hip joint. So that's an articular branch. And also the skin on the middle aspect of the thigh, that region there. So that's the distribution of the anterior division. Now, take note that the adductor brevis is supplied by both posterior division and anterior division, and that was a contentious dual innervation. So in this image, gives you a summary of its origin. The root value L2, 3, 4, that's a common nerve, and then the two divisions, posterior division going to obturator externus, adductor magnus, and is the one that also goes to the adductor brevis having dual innervation. That's that one there. Then it's applied the skin, the knee joint. This is the one that passes through the adductor canal. I told you about a twig from the obturator nerve. This is the one that passes through the adductor canal. It goes together with the superficial femoral vessel to the adductor hiatus to go to the knee joint. The anterior division supplies all the other muscles of the adductor compartment, including again adductor brevis, but it also supplies the hip joint, and it has a cutaneous distribution on the middle aspect of the thigh. Now, as clinical relevance, we commonly hear about pain referral, considering that obturator nerve supplies both the hip and the knee joint. Sometimes you may have pain referrals. Pain arising from the hip joint may be felt at the knee or vice versa. Pain arising from the knee may be felt at the hip. Why? Because the two joints are both supplied by the obturator nerve. Great, so that is the story of the obturator nerve, and that summarizes the story of the topographic anatomy of the thigh. This has been very long. I didn't anticipate it to be that long. If I knew earlier, I would have split it into two, but we're done. So we looked at all our objectives. Thank you very much. That will be the end of it. The next topographic anatomy class will be on topographic anatomy of the hip joint. So we've done the first two. The next one will be that one. We'll stop there for now.